transitional housing, community advocacy programs, rural advocacy. They work in Franklin and Jefferson counties as well as Douglas. Human trafficking. Did you know the Willow provides confidential advice, information, and advocacy for survivors of human trafficking and domestic violence in our county? And education and prevention. If you have a group that you would like them to speak to, they do programs. If you'd like to know how to donate and support them, stop by. Very worthy frontline, 24-hour hotline. It's manned 24/7. All their services are free. 785-843-3333. During this time of toxic masculinity, we're hearing more and more statistics. Our young women are at risk. We need these advocacy groups. We need to support them. So I'm putting a special plea out there for them. Ballard Center is represented here with their community, with Nick in the back, Bert Nash with their mental health, Douglas County Public Health, and LMH as well. And please stop by and support all of these organizations that help provide for the needs of our young women, and especially during the vulnerable times of pregnancy. So we are going to hear some startling statistics. Oh, one more little bit of information I saw in today's paper. My husband notices how I cut things out of the paper all the time and have them floating around. This library is an amazing resource, and I do thank our library staff for their support. The Lawrence Douglas County Public Health organization is hosting an event called Public Health After Dark, Thursday, March 27th from 6 to 7:30 here in the library to talk about violence in our county. So that's something to watch for as well, Adina. Pardon? As well, thank you. That was the last thing on the list that I would almost skipped over. Women for Kansas is also working on organizing a town hall with all of our congressional delegates. It will be a webinar, a Zoom webinar, and the date is April 7th, 7 p.m. Again, if you go to womenforkansas.org, or if you go to our Facebook page, we'll have that information as well. Okay, are there any other announcements I've neglected? I want to be sure. So there's lots of groups you can connect with. Today we have these amazing women, outstanding women who are doing above and beyond in their fields, trying to bring us good quality health care and speaking out for the vulnerable in our communities. We're going to hear some startling statistics and some dark information. And so before we begin, I wanted to share something positive, a positive maternal health outcome. So 2 years ago, our daughter was expecting, our first granddaughter. And after ushering a Lead Center event, my husband and I went home to see that our phones had blown up with messages we hadn't gotten yet. And she was in the hospital 3 months before her due date. And so the next day we went down to Wichita and spent the next week with her. And at the end of that week, our granddaughter, Nora, was born, 3 pounds, 12 ounces. She was born 10 weeks early. But because our daughter had good health care, because she wasn't turned away at a hospital like she might be in another state, because she had support and the blessings of the miracle of just, it was a miracle. Our granddaughter is showing no signs of this premature birth. She's developing wonderfully, she's happy, she's got a sense of humor, she's learning. And I just wanted to share that. I'm sure each of you holds in your heart some positive maternal health outcomes in your own families. And I just wanted to share that as a reminder that this is our goal. It's life and well-being. Okay, so for today we have Dr. Ashley Bloom. She's my family physician, and she is a local family physician here in Lawrence. She serves and practices in East Lawrence, which is a historically underserved area. She's a graduate from the KU School of Medicine in Kansas City. She's a lifelong Kansan. Her mission is to leverage social drivers of health to improve health outcomes for our community and her patients. She seeks to provide individual, family, and community-centered care. She also serves walk-ins at LMH South. She completed her residency at St. Joseph Family Medicine in Denver, Colorado, and before moving home to Kansas with her spouse to raise her family, she provided care throughout rural Colorado and Kansas in critical access hospitals and clinics as a local physician. So please help me welcome Dr. Ashley Bloom, our moderator.
Thank you. I can't think of a better way to spend this afternoon on International Women's Day than accompanied by these wonderful women who work in the field of public health and caring for our community and our state as well. So I'll briefly introduce, I'm sorry, I'm not going to hit all of your wonderful, fabulous accolades because I think that would take the rest of our time today. So we have Dr. Sharla Smith from the University of Kansas School of Medicine. She's also the founder and executive director of the Kansas Birth Equity Network. Then we have Dr. Beth Oller. She is a family physician and a mentor to me when I was a student and she's practicing at Rooks County Health Center. She's also very active with our state chapter of the Kansas Academy of Family Physicians. We have Lauren Alexander, who joins us from Burt Nash Mental Health Center. She also has experience working at the state level with the Kansas Department of Health and Environment, ADHD. And then rounding us out, we have Dr. Betsy Wickstrom. She's an obstetrician who specializes in maternal fetal medicine. She takes care of high-risk pregnancies and has been practicing in the Kansas City area. She additionally has a number of advocacy groups and is a great source for helping us understand how to engage with impacting maternal health from a political perspective. Oh, sorry, your names. So to kick us off, I want to talk about the social drivers of health because this is something that once you hear about it and you get this kind of very, very high level overview that I'll be talking through today, it's something that just makes sense. So the social drivers of health, these are the conditions that people work, live, and play in. And so these have impact on our health. Things like access to steady income, having education, housing, stable and safe housing, access to healthcare, having neighborhood safety, being able to go walk around your neighborhood to get physical activity or to walk to area businesses or to a local grocery store to get access to healthy food. And then community support. And this is, I think, key, especially with Lawrence and Douglas County, that we have a wonderful community and lots of engaged folks who want to help support the other folks who live in our community. So you'll hear the D, so this is shortened to SDOH frequently. The D will either interchangeably be called drivers or determinants. There's been a move away from using the word determinant because it has this kind of finality that there's a predetermined outcome. But that's not what we're here for. We're here to drive change, to leverage these factors to help people reach the best possible health they can. So this is a great visual of the different aspects of SDOH. So looking at this, you can see that education and access, understanding how to read information that your physician or your healthcare provider gives you to understand your condition, that requires education. Math skills, math literacy, to understand medication dose changes, or to make sure that you have enough pills of the medication that you need to take on a regular basis. We also see that healthcare access and quality is key. So unfortunately, in our society, that includes access to insurance because of the cost of healthcare. We also see access. So do you have providers who speak to you in a way that you understand? Are they available when you are needing healthcare, whether that's in location or time or day? So this healthcare access and quality has a big impact. But then we also look at the neighborhood, the built environment. So this is, again, the conditions where we work, play, and live. Is it safe to walk your dog on the street? Is it safe do you have access to transportation to help you get to your doctor's appointments, to be able to get to your employment for a source of income? Social and community context. So this, we talk about factors of community cohesion, having connection with each other, which I think all of us realized throughout the pandemic, and social distancing is vital for our mental and physical health, as well as our community health. We also see in here levels of discrimination and institutionalized racism, and how that can impact health outcomes. Finally, rounding us out, we have economic stability. This has to do with income level, having employment. Employment is tied to access to insurance, being able to afford basic needs such as food, clothing, your home. So then we take a look, okay, so we've talked about the SDOH, the social drivers. Well, how does that tie in with political determinants? The political determinants are the parts of government and policy that really create the social determinants or the social drivers of health. So this can be broken down into three kind of key concepts. The idea of voting. So who are our representatives? Who do we vote to represent us in making these policies? What are the policies that are created? And then finally, government is the actual act of distributing resources and then creating the space and the environment where people live. In healthcare, it's one of the perfect examples of a political determinant, or how political determinants impact health, is the example of Medicaid. Medicaid is an insurance program that is co-funded by the federal government and then state government. And this is for people with limited income or resources to make sure that they're able to access health insurance. When we look specifically with regard to Medicaid, with maternal health, when women are pregnant, regardless of their insurability, they're eligible for Medicaid coverage. And so this is something that when we look at Kansas from the years of 2018 to 2023, about a third of babies born were born to mothers who were covered by Medicaid. And so when we think about giving children and giving babies the best opportunity to have access to care, this is a key component here. So with that, I'm so stoked to have our discussion and to just be able to have a conversation and really talk about how the political determinants interact with the work that each of you do on a daily basis, and how this plays out in our communities and our states. So I'm going to ask each of you to introduce yourselves a little bit more robustly and give kind of a high-level overview of how the political determinants work in with your day-to-day work. Betsy, would you like to start us?
So, I have been working as a high-risk OB for 31 years in the greater Kansas City. Which tells you, I don't know if I keep holding this button down, just a second, let up, see what happens. Hey, the green light stays on, hallelujah. I'm getting a cramp on my hand. Which means that I go back to well before all of that access to Medicaid came in for pregnant people. So one of the things I will want to talk about today was just the night and day difference when pregnant women began to be able to access Medicaid, to access low cost or no cost medical care. I was never a political animal at all until the summer of 2022. So remember what happened then? Yeah, you value not them both. And so then I was showing up at county fairs and talking to people on the sidewalk about what it means to have bodily autonomy and not letting the government take that away from you. And then that has just sprung into, gosh, a couple nonprofits and a little side gig of, helping people understand what's happening with their state government and what they need to know to be informed voters. So, this kind of ties that up in a bow.
Hi, I'm Lauren Alexander. I'm a licensed professional counselor. I work for the Burt Nash Center. I also work for KDHE, so I sat on the Maternal Mortality Review Committee. I worked on maternal anti-violence grants. I was the project officer working in Kansas to end violent maternal deaths, which are deaths that occur by homicide, suicide, poisoning, and overdose. So that's really the lens that I look at. I also have education in perinatal mental health disorders, and I'm really here to talk about how Burt Nash Community Mental Health Center can really help improve that access to quality care regardless of a person's ability to pay.
Hi, I'm Beth Oller, and I am a rural family physician in Brooks County, so right middle of the state. Have done full spectrum family medicine, including obstetrics with surgical obstetrics. Did that for 13 years until I stopped a little over a year ago because I was the only one left in our county who was doing that. So I was on 24 hours a day, 7 days a week because of that. And so, one of my points, 50% of Kansas counties are considered maternity deserts, which means there's nobody in that county who is either delivering babies or doing prenatal care. And so I used to always see that map and it would break my heart, and then I felt like I had failed when our county went on that map. And that was not ever anything that I wanted to see. My first baby is here. She was born at our rural hospital, and sitting by her, one of my closest friends who was also, we got to do some amazing things in a rural hospital. Avery was my doula for our patients. We offered a no-cost doula to our patients, and she met with them beforehand, and she stayed with them all through their birth, and we had her as a lactation consultant, and we got to do some really special, amazing things. We offered water birth because that was something our patients were needing, and so you can make some really amazing things there, especially as family medicine, being able to be with our patients from before they get pregnant, when they get pregnant, after, and then see the babies. And one of my greatest joys is watching all of my kids that I've delivered grow up. And all four, I'm the mother of 4 kiddos, and they would ask, like, which one of these are yours? And what they meant when we were somewhere was like, who have you delivered? And so that's very special, but we have so many maternity deserts now that it's difficult, because if you're making your decision between taking an entire day off work because you've got to drive 2 hours away to an appointment, spend your 2 hours at an appointment, drive 2 hours back, there's only so many days you could do that before you're going to lose your job most of the time. And so, moms will get labeled non-compliant because they don't keep their appointments, and it's not that, it's that or paying your bills. And so that's why it's so important to try to have care in the communities that a person is in. I was honored to serve with Mel and many others on the expert team for Kansas Connected Communities, Kansas Moms in Mind, which is when we started the state thing about 5 years ago to really focus on maternal mental health, because we know that, I had written down, but we know that 1 out of every 5 women suffer from a PMAD or a perinatal mood disorder, and suicide or overdose is the leading cause of death in women in that postpartum year, in that postpartum period. So it's so important to know our resources, to do what we can, and to kind of gather around. And then one of my other big things is gender affirming care, and only provider west of Wichita that does gender affirming care. I take it very seriously. I've served as the expert witness for the ACLU, and we sued the state of Kansas about not allowing gender marker changes. I've been really involved in the same thing with not allowing, of course, care for kiddos under 19 now. My patients have been joking with me, like, are you still gonna be my doctor next year? Meaning, I still have a medical license, because that's part of what would be pulled if you continue to do the care for people under the age of 19 who are transgender. Is it's not only them not being able to access it, but it is also actual now litigation towards the physician, where any of us who did it would lose our medical licenses. So not just to do transgender care, but to serve any of the thousands of patients that we serve in the state. So that's another it ties in, you know, so much with social determinants of health. Can I access my care? And then when I'm talking to my transgender and non-binary patients, it's so often not just accessing that care, not just their hormone treatments, not just those things, but they don't access medical care in general because of such negative experiences with accessing care, not knowing if they're safe, not knowing where they'll be respected. That preventive health needs go by the wayside as well. And, you know, we are one of 10 states that has an expanded Medicaid. We pay all that money in anyway. We just get none of the benefit of it. And right now in Kansas, out of our 104 rural hospitals, 60 are at risk of closing and then 29 are at immediate risk of closing. And the states with the most rural hospitals that close every year are Kansas, Texas, Tennessee, Mississippi, and Alabama, all of who have not expanded Medicaid. So we're gonna continue to see lack of access of care to our rural communities, the longer we keep from expanding Medicaid. So, sorry, those are all my soapboxes.
I don't know how to go after that one. Great work. So I am Sharla Smith. I'm faculty at KU Med in Kansas City, Kansas, and in the Department of Population Health and also in the Department of Obstetrics and Gynecology. And I do a lot of research on Black maternal and infant health. So I look at the entire family, really looking at if we can improve Black maternal health, we can improve everybody's maternal health, right? And so I do community engagement, I do advocacy, which I call power, the little advocacy I can do, training, as well as education through my work and research on early disparities in early onset preeclampsia, which are really geared toward pregnancy-related hypertension and making sure that that is controlled and monitored in patients. And we're currently developing a doula-led, a community-centered, doula-led intervention for group prenatal care that will be virtual for our community, and I'm writing a grant now to expand that to be across the state of Kansas, not just in the Kansas City, Kansas area. So really looking at that and having each one of those patients have a virtual doula. But I do have a disclosure. Everything that I say today is going to be representative of Sharla Smith and not the University of Kansas. So I have to say that. So nothing I say will represent the university, except for the research that I do currently conduct on disparities. And, you know, when you look at the political determinants of health, you see equity. And equity right now is really under fire. We know that it falls in DEI, diversity, equity, inclusion, and so many individuals don't understand that health equity and DEI are two different things. So health equity, we really, as the Kansas Birth Equity Network, we define health equity as shifting the blame from mothers to poor health outcomes to policies and procedures and systems level accountability, right? And so if we look at health equity in that way, we're not saying that someone gets more than the other. What we're saying is whatever policies and procedures have been placed into a system to exacerbate these disparate outcomes, we're going to address, right? Whether it's a mom is being tested for drugs. So, you know, one of the things that Katie did that I'm grateful for is they put different procedures in place to really control like who was being drug tested when they came into the ER and they were pregnant, because a lot of women get drug tested, and that is not about it's not really about whether or not they're doing drugs. It's a delay of care, right? And who's getting chosen for those random drug tests? Who do you think is getting chosen, right? And so often it's the underrepresented individuals. It may be, you know, poor individuals, it may be overweight individuals, it may be Black individuals, it may be Hispanic individuals, but really looking at how do we change that? How do we get parents more civically involved with something that the Kansas Birth Equity Network is really looking at now, not to tell them how to vote, but how to actually look at what's happening across your state and how it impacts you, whether that's food prices, whether that's, you know, politics, Medicaid expansion. We are battling Medicaid expansion in our state because our legislators don't like our governor. We're giving millions of dollars to the federal government that is going into some other state to improve the other state's health while our state is suffering, right? Each year, because our people cannot get along. That is concerning. I mean, that is impacting our families, that is impacting our children, that is impacting our healthcare systems, especially in our rural communities. There is no reason our hospitals should be closing, right? And we know from the data that every state that does not have Medicaid expansion has an increase in maternal deaths. Every state that doesn't have legalized abortion has an increase in maternal death. We have legalized abortion with a little scrutiny, but we have a high maternal mortality rate, and we're seeing those increases across the board, but we're absolutely seeing them in Black moms. Kansas right now has the highest Black maternal mortality rate in the nation in the first 42 days of life, according to the American Health Ranking Society. So 42 days after giving birth, we are losing the most Black women in our state, and we used to have about 13% pregnancy. Yes, that's right, baby. But now we have about 8.9, which is really, really not good, right? So we have less people having babies, but we still have this high maternal mortality rate. And if we can't improve the health of mothers, we cannot improve the health of children. We cannot improve the health of their partners because they're having to take care of their mothers. And for every one death, every one death, we have 100 women that suffer severe maternal morbidity, which means they're really, really sick, right? And so if we are talking about like what's happening, we're having about 10,500 Black women that suffer severe maternal morbidity every year in our state. That's not good. We have sick individuals that can't pay taxes. They can't go to work every day, right? They need health insurance or they need health care, and they're getting it either with insurance or without. And that is a large issue. When they go to the ER, they're getting care because the ER has to give them care. Well, who do you think is paying for it? Us. That expense is passed on to the citizens, it's passed on to the consumers, right? So not only are we giving money back to the federal government, but we're double paying for health care in Kansas. We're giving money to the federal government every year to go to another state, and we're taking on any of debt that anybody produces when they're going to get health care. Your groceries are higher because somebody's stealing groceries, and somebody's getting benefits, and so is your health care. But no one ever looks at it as health care. It's like they're passing that on to the consumers. And so that is a major political issue. Whether we talk about it from policy, or we talk about it from healthcare outcomes, or we talk about helping the poor, we talk about helping those who are unemployed. These individuals in the state of Kansas are working individuals. A large number of these individuals are working every day but cannot afford health insurance. So we're not talking about taking care of the poor. So we have to really change the way we're doing things in our state. And we can't just expect the minority of Democrats to make the change without the support behind them. If you have a legislator that is really doing the work, make sure that you support them financially, you support them and let them know about the good things that they're doing, and ask them how can you know. So we're really working as the Kansas Birth Equity Network to do that and to train physicians to do that. We take our physicians to the Capitol, just went last week, to visit legislators, and so that they can improve the education that they have about healthcare. Now, does it work? It's not working yet, but we hope it works one day, right? But the goal is to continue having these conversations, and they are with bipartisan legislators, and we are seeing some interest in the conversations, and they really have the knowledge to help them to make informed decisions that they haven't started making yet, but they will one day. So that is some of the work that we do.
Thank you. So I think it would be interesting for us to talk about this perspective of Medicaid for covering women when they're pregnant. What would it look like if women were able to access Medicaid without being pregnant? If we had Medicaid expansion, what kind of differences might you see as far as health outcomes or ongoing before getting pregnant to allow women to have better health care?
So in my perfect world of puppies and rainbows, I would have a chance to visit with every person of childbearing age before they actually conceive. And we would talk about what it looks like to take care of your body and make your body a healthier place to grow a human. What do you need to eat? What vitamins do you need to take? How do you need to move your body? How do you need to take care of your mind and your spirit in order to be the person that can have a healthy pregnancy? And no one can get access to me if they don't have insurance. And that's just J&Q public, right? That's not even including the type 1 diabetics and the hypertensives and the people with seizure disorders. Those are the people that need to see a high-risk specialist, preferably before the horse is out of the barn and down K10, right? Before that little fetus is already formed and their parts either formed right or they didn't, before that placenta gets a chance to grow or it doesn't, and that can lead to that early severe preeclampsia that you're studying. So having people having access to well-person care instead of having to wait. So when I was in high school, all right, I'd known since I was 12 I was going to be a doctor. That was an audible calling from God. I'll tell you that story sometime. But when I was in high school, I knew that I wanted to do women's medicine because it's preventive medicine. It's your mother that makes you take your vitamins and wear your galoshes, right? It's all, that's what I knew I wanted to do. And so having these maternity care deserts, having so many people that are, maybe they're a single parent and they're having to work 2 jobs just to put food on the table for the kids they already have, and having no access to health care, so they have to wait until they're sick and then they show up in the emergency department. We just talked about that. So to me, if you begin with a healthy person, you're going to have a healthy pregnancy. My sister, who lives in Omaha, will find out somebody's pregnant in the Kansas City area, and she'll say, do you know my sister, Dr. Betsy Wickstrom? And they say, no. She says, good for you. Because it means that they work in a high-risk scenario where I can come see maternal fetal medicine. I want to keep everybody right in family medicine with OB. That's a really good goal for me. I want to keep all of my pregnant people in the hands of my favorite midwives. That's where pregnant people belong, but without access to Medicaid, it's never going to happen in this state.
And I know that the question is specific to women, but for women to thrive and be healthy, they need their partners to also thrive and be healthy, so that they can raise their families. So, expanding Medicaid does improve the health outcomes for women, for everyone, because they really need the supports around them. So when women have a maternal mental health condition, the likelihood of their partner also having one exponentially increases, and then we have no way for them to access care or anyone screening them or providing interventions or services.
It is insane to me that we still don't have Medicaid expansion. It is one of the first things, I'm old now. I went to medical school 2008 through 2011. No, I did not. I went to medical school 2004 through 2008. I was like, that was residency. That was residency. But I can remember my first day on the Hill in 2004. And my first Kansas Academy of Family Physicians meetings, we were talking about this. Friggin' 2004, right? Like, it has been forever. It was one of those, we'll keep bringing it up next year and next year and next year and next year. Like, we'll keep going, we'll keep going, we'll keep going. And it might not have been Medicaid expansion in exactly this iteration, right? But we were still fighting back on doing these things.
Because our legislature had passed it and Brownback didn't sign it.
Yes.
Wouldn't sign it. So
Wouldn't
that's how
sign
how
it.
far back this goes.
Yeah, and that was one of those things where it was like, yay, we did it, we made the difference. Oh, okay, back to this. And I was in the Kansas Reflector last year fighting with Dan Hawkins in a town hall in our town that he tried to refuse to let anybody else talk at, and I'm real good at not being refused. So he asked a rhetorical question, which was, who on earth would take care of these people? And I was like, there we go. And I stood up and I said, I would. And my partner would, and my other medical partners would, and we would take care of these people. We do. We don't have a Medicaid cap. We don't have a Medicare cap. And so it's continuing to do things like that, and I'm so happy to have a representative here. Yay, and to meet you. But it hasn't, it's one of those, it doesn't matter enough. I talk to my legislators and I'm like, this is why it's important. They're like, yeah, I know, but there's no political pushback for them when they vote against it. And trying to, expansion would let us have coverage for 150,000 more Kansans. And what so many people, no matter how many times you say it doesn't get out there and it gets pushed down, that is 90% federal government cost, 10% state. Like, we would be able to cover that many more people with such little cost to the state. And that when you do expansion, even that little cost that is to the state, you get it back. How? Because people are healthier, because people are working more, because people are paying taxes, because people are putting their money into local economies, because people are able to stay in a state. And things coming out now, like when we were fighting for abortion access, we see this in doctors who are studying and training, all right? Nobody who's going into OB-GYN now, nobody who's going into family medicine with OB is going to train in Florida, is going to train in Texas. You're not going to train in these places where you don't get adequate training, number one, and where you can have litigation against you for practicing within your scope of care.
And those people in training are of childbearing age.
Yes.
They're not gonna be in those states.
They're not gonna be in
We're gonna
those
let them
states.
die.
And you don't do, we know that where do people mostly stay after residency? In the states where they did their residency. You're not doing your residency in a state that does that. And we've seen this, and there are studies on this already. But I talk a lot to different AP reporters and people when they'll just call for just like some info, even just background. And I'll tell them, we're gonna start seeing this. Like, we are now seeing now with what just got passed with transgender healthcare, that I could lose my medical license and be litigated against for up to 10 years after the child turns 18 for doing something that is in my scope of care, that is medically based, evidence-based medicine. And people are not going to practice in those states. But you also think of the heartbreak of families who go, I can't stay in this state anymore. The people we will lose because they cannot access necessary medical care for their children, for their loved one, but also just the idea that if you're in a state where you can't get medical care, period, and there is a state that's around that maybe you can, you're going to go those places. I am going to be president-elect at the Kansas Academy of Family Physicians, and it will continue to be one of our high priorities, but I will continue to be probably louder than most people want me to be on these things, because that's who I am. One of my, not mentors, I've never had the honor to meet him, but Dr. Paul Farmer, who is an astounding humanitarian. His quote, and I have it up in my office, it says, if access to healthcare is a human right, who is considered human enough to have that right? And it's one of those things that when I read that and focus in on it, it recenters you. This is about so much more than just healthcare, right? This is about seeing each other as fellow children of God. This is seeing each other as fellow people who we walk this world and this life with, and being the kind of people that I want to raise my children to be, which is those who care for others in whatever way that is. My way is healthcare, but there are so many ways that we can touch and help, no matter what area of life it is that we serve others.
So I think everyone on this panel have answered the question, but I think it's interesting that in 2025, I'm on a panel and someone's asking me why it's important to have Medicaid expansion for individuals before they get pregnant when women are dying. But no one's asking me why it's important that I pay car insurance every month and I never get in an accident, right? Nobody's asking me, but I think it's the reality of things, right? Like, what are we talking about here? Are we talking about human rights, or are we talking about economy, or are we talking about egos? And I think that it's not about human rights, because no one's going to let me register my car if I don't have insurance, right? And the insurance is so if I get in an accident, right? But we don't wanna insure women and families if they are going to get pregnant, right? And we're a pro-life state, right? So we want people to get pregnant, we want infants to live, but we don't want to insure women, and I think that's an issue. And not only can we insure the 150,000, but we had 114,000 individuals lose their health Medicaid since 2023 in our state. So we're not talking about 150,000 individuals, we actually are talking about 264,000 individuals that deserve care in our state. That is a whole entire city in the state of Kansas, right? And those individuals need health care not because they're poor, but because they're going to work every day. In order to stay healthy, they need to have insurance, right? Because most of these are working individuals, right? But healthcare is a right. We should get healthcare. Right. And it's only probably about a third of what they need to actually get the quality healthcare that they deserve. Healthcare is just one component. And so we can't give one component as a pro-life state and Christians, believers, says the Bible says, what you do to the least of them, you do unto me. So if they're the least, who are we doing it to, right? Because that's who we are. We're in the Bible Belt, we're pro-life, and we have to really exercise that right of having each and every person in our state, regardless of how we feel about them, regardless of what we think, because I do equity work. I don't care how you identify, I don't care where you were born at, I don't care where you live at. If you have a baby, I want to advocate for you. I want to provide resources to you. If you have children, if you need help, I want to be that person. I don't care anything about how you come to me. I just care how you leave when you come to me, right? And so I think the reality is, as a state, do we care about each and every person in our state, or do we want to put people in boxes and say who's more human than the others, who's more deserving than the other person, right? And, you know, I came from a Medicaid expansion state, a red state, Arkansas, and my parents are not going to leave there because there's Medicaid expansion and they're older, and it even benefits you and pay for it. Right? If you go to the store, you pay for something, and they don't let you take that out of the store, what are you gonna do? You're going to put up a fight, right? And so here in Kansas, we're giving money to other states to be healthy, and some of us, probably everyone in this room, is putting up a fight. But there's some people that's just giving out money and not putting up a fight because they don't think that people deserve it. And I just can't have a conversation about what people deserve and don't deserve. I am not in that.
And I think another point where we can bring people in on Medicaid is people do not realize that that is what provides nursing home care. Right? They're like, I don't need that. I don't need Medicaid. Like, I got Medicare. Not once you're in the nursing home, you don't. And people are mortified that, what do you mean? Have fun paying for your parents, your grandparents, your own one day, being able to have that care if you need it, because that is Medicaid. And I can remember, you do too, when we got to cover pregnant women until 6 weeks postpartum.
Yeah.
Or then it was 3 months postpartum. Felt lucky as hell when we got to expand it to a year postpartum. It was like being given a present. But that's also ridiculous that feels so amazing that we could actually keep them to a year. Yeah, what would I do? Like, fewer unplanned pregnancies for one thing, right? That's one part of what can we do if we had expansion. You can have preventive health care, and you can have those conversations with people beforehand so that they can actually have that pregnancy when they want that pregnancy and when they're ready for it. You have moms coming in who have had updated preventive care, so you have been able to take care of that blood pressure and get it down and get that hemoglobin A1C where you want it before they conceive. You've had those conversations. Oh yeah, I was gonna say, so maybe they don't know what hemoglobin A1C is. When you are diabetic,
That is the number I look at, that I'm like, yes, it's where I want it to be. It is the average glucose of over 3 months. So when I look at with any of my patients, I have these numbers, these targets for healthiness, and you can have those conversations with moms beforehand. A lot of the work, especially Mel and I do, you've been able to have those discussions with them already of things like, do not stop your mental health medications when you find out you are pregnant. And so, because to us that's normal, right? We're just like, no, why would you do that? But people are told that by other physicians and providers, and we could have had those conversations beforehand of, let's plan it. And if there is a medicine that they're on that maybe isn't optimal, what can we do to get that talked about beforehand? And then, start identifying those support systems before they're pregnant. Start knowing about the things in the community or at the beginning of the pregnancy. Like, those are the things Medicaid expansion can do. But also, a mom, great, I get to take care of her until a year afterwards. And then apparently she stops mattering. The kid still matters, which of course we know they all matter, but then her health stops mattering. So say we've optimized things and we've gotten things great and we're where we want to be and her blood pressure is better, but now she doesn't have health care again. Can't afford her meds. And we're gonna be back in the same boat of possibly a high-risk pregnancy if another pregnancy happens, because also not able to see somebody for preventive med or to take care of contraception or to be able to have those conversations.
The contraception issue is so important, because how many people have come back to me pregnant because I missed their 6-week checkup, and then they come in at 8 or 9 or 10 weeks and they're already pregnant again. And we have the conversation, really we do, but maybe they're in a scenario where they're not really having a choice about whether they're having intercourse that soon after their child is born. And if I don't have the resources to keep them in the system and keep them supported, that's how that happens. And when it used to be just 6 weeks, you want your tubes tied, right? Unless you have it done like the next day in the hospital, you have to wait until 6 weeks when the uterus shrinks down and it's nice and tiny, and then you can get laparoscopic tubals, right? But if your Medicaid runs out at 6 weeks and you don't get in and have that procedure done, and that was going to be your birth control, now we're up the creek with no paddle. So a year was a real godsend to me. But it's true, how many women do I care for that I send home from the hospital after delivery on 2 or 3 blood pressure meds? And if they can't continue that care, how are they gonna be around to care for the child they just had? Tell me again how we're a pro-life state.
Lauren, I'd like to ask you to weigh in too on how does the that time difference, what from a mental health perspective for maternal health, what's the difference between 6 weeks to 3 months to a year?
So perinatal and anxiety disorders, the onset can happen at any time. The vast majority of maternal deaths that we see though are actually in the latter part of that first year. So the suicide, accidental overdose, and homicides, those happen later. And so that's why continuing that care, and it's not that that risk stops at 12 months, it's that we stop studying it, right, because the MMRCs go to 12 months. So you're still postpartum past having MMRC is a maternal mortality review committee. So that's how we get all the data, to give us the information to create the policies or to provide guidance on the policies. So yes, so that 12 years, but that's really where we stop examining the deaths.
I know I'm the moderator, but I also, as a family physician, want to chime in that many of the conditions that women experience during pregnancy, when I was in training, our labor and delivery unit was technically an ICU. It was critical care level, because that is how tenuous and how quickly the status can change for a woman or a baby during the labor and birthing process. And at the hospital where I trained, we saw some of Colorado's highest risk pregnancies. About 10% of babies born in Colorado were born in the hospital where I trained. But then we would follow them after, and we would see years later, women who had had those high risk pregnancies, who had preeclampsia, which is very, very, I'm gonna miss some of the medical details, but part of that is just a high blood pressure, and then that can put women at risk for hemorrhage, for seizures, for death. That risk doesn't go away right after they deliver. That can continue postpartum as well. A woman who has had high blood pressure during her pregnancy has an increased risk for the rest of her life for developing hypertension. Same with diabetes during the pregnancy time. Those are women that I need to keep seeing on an annual basis just to get a blood sugar check, just to get that A1C, so that if they do develop diabetes, we're able to intervene and help manage that disease for them. So that's my, sorry. What are, as we look at ways to help advocate or to move the needle, to change this, I mean, we've talked about the enormity of the issue of access to medical care for women during pregnancy, before pregnancy, after pregnancy. What are some action steps or some positive things that we are seeing?
You know, I think that it's great that we don't have to reinvent the wheel on this stuff, right? There are policies and places and countries and communities where health outcomes are positive. So we're not starting from scratch. We can look there. I think in terms of violence against women, Oregon has and really positive policies for women, which is paid family leave. So Oregon as a state has paid family leave, which can be taken for any number of reasons, but that includes pregnancy, postpartum, and also escaping a domestic violence situation. And that's available to all of the citizens where we work.
Yeah, in Kansas, we're currently working with the KBC, Kansas Breastfeeding Coalition, Kansas Birth Justice Society, Thrive, Allen, Kansas, and other organizations to work on a paid leave deal. So this is the pre-work of like identifying how much it would cost, which is like $6 a month. But who would be eligible, and not just for parents, but this paid leave bill would include anyone who needs to take care of a elderly or a sickly family member, as well as for themselves, because everybody doesn't have paid family leave. You work at Walmart, you're going back to work after having your baby, you're not able to breastfeed, you're not able to take your baby to work, you don't have any of those plans in place. And so that's really positive work. I think the other positive thing is you guys are here. Like, we're all still having the conversation. None of us has quit. I mean, we've been trying to do this for a long time, and you guys were trying to do this before I came here. But I think the reality is, like, oftentimes people give up. They're like, it's too much. Like, let's focus on something else. And we have not quit. We continue to focus on the health of women, the health of their partners, and the health of their children, which is really important to have a healthy community, right? It starts with mom. Life starts with mom, and then life continues. It doesn't start before mom. Like, we need mom for life, right? And I would say husbands would agree with that we need mom for life. But the reality of that is that's positive. I think the other positive thing is that we are seeing, we do have postpartum extension where women can get care up to 12 months, and we can thank our governor for that. I don't think we spend enough time thanking people for the things that they do to put it positive. We just focus on what's still wrong. And so focusing on the fact that our families can continue their postpartum care, and we should be out advocating for them, because that is still a gap. They are supposed to go back to their family medicine doctor if they're not currently seeing a family medicine doctor for that postpartum extension. And we know that families are mothers are following in the gaps of that. They're getting canceled appointments from their family physician, but they aren't able to go back to their OB. And I don't know if you've ever had a baby. I did it. You just don't have time to go back and forth with your mom. You're not getting sleep. There's someone else to take care of. There's a lot going on. So we need to be advocating for that. But that's a great thing within our state. Our state also has legalized abortions, which we can agree or disagree on abortions, that's fine, but we can all agree that an abortion is a decision between the patient and their physician and not the legislature. I think we can look at that, and that also puts us in a place where OBGYNs and family medicine docs that do obstetrics can practice at their full scope of work in our state, because they can't in other states, right? But I think those are some great things that are happening throughout the world, and we're still creating. Kansas, we're not doing the worst, right? We're still in Black maternal health we are, but we're not doing the worst in everything. I think we're still doing the work to make it a better Kansas for everyone who lives here, right? And I think that that's positive as well, that people actually care. Not that Kansas nice, because I don't think that's caring, but I think the policies that really help people to have a better life in our state is caring. And so,
I think one thing that's positive is I am frustrated as hell in our legislature and have been for years. And the main reason is because I do not believe that is who we are as Kansans, as a whole. It's not. We are not people who want to restrict or decrease human rights or don't give a crap about each other. That's not who we are. And our friends that live in other states would always be like, you guys are red, you're red, you're red, you're red. And it's like, we're purple. Like, we're not so red, we're purple, right?
Kentucky was the first state that has that.
Yes, Kentucky was the first, and it is red, but what I mean by that, like, we're purple, is that in general, it is, a lot of people may vote conservative for certain things, then we have some pockets of more liberal areas, but the purple to me speaks of, we in general care about each other. We are the kind of people that can say, I might not agree with that. Same thing on transgender care, right? Would you do that for your children or not? Have a transgender child, and of course, it's gonna change the mind of everyone. But abortion, yes or no, these kind of things. We can have differing views on this, but the thing that most Kansans agree on is, I may not understand, but it's not my place to make that decision for you. I may not understand, it may not be the decision I'm gonna make, but I don't have the right to say what you get to do with your body. That is who we are. So again, my huge frustration with the legislature and the legislative process comes from, I do not feel like we are represented as Kansans. But that's also what gives me hope, is that things can change, that we can get other people in, but also that I feel like my fellow Kansans are people who care. We are people who care about each other. We are people who want to see things be better for everyone. And so that gives me hope.
I agree, and what gives me hope is what roped me into this whole idea of becoming politically active in the first place, which is that despite the millions and millions of dollars that went into the Value the Vote campaign, Kansans stood up and were the first ones to stand up after the Dobbs decision and say, no, you may not take away our civil rights. You may not give me, as a pregnant person, less rights than a corpse. You can't take organs out of a dead person unless they've signed their organ donor card. On the other hand, a pregnant person can be told they have to give up their life for a 12-week embryo. No. And that was the kind of thing that I talked to people about during that time. So that's my bright spot, is that we stood up and we said no. Here's my downside to that. The SCR, the Senate resolution that just passed on Friday out of the Senate, SCR 1611, would take our merit-based way of electing or appointing our Supreme Court justices, and instead of being appointed by the governor from a panel of people suggested by all the lawyers and judges, like on this huge gathering, to say, hey, here are the people that really are upstanding, and here are the people that are doing an amazing job, and then the governor, okay, I pick this one. Instead of that merit-based process, this would be an amendment to our state constitution, like Value Them Both, so get ready to vote no, that would say that the justices would be political actors. They could hold offices in a political party. They could receive and give political donations, and completely lose that apolitical, let's actually look at the merits of the case, and instead they can be bought and paid for. You think the Koch brothers aren't ready to send millions of dollars into a campaign for a state constitutional amendment? Bought and paid for. That's what you're gonna see. So get ready to vote no again.
We're gonna interrupt real quick. Because Adina, sorry, follow up.
So glad you said that. You only have a right to abortion in this state because of our Kansas Supreme Court. We didn't add the right to abortion to our Constitution. We merely prevented our Constitution from saying we didn't have a right. The actual decision in Hodey's Nauser case came down in 2025. If the makeup of the Supreme Court changes, then, and stare decisis doesn't matter, which means following precedent, like it didn't matter in Roe, we will lose it. That's the game plan, 100%. There are green sheets back there that I created. One talks about SCR 1611 and the connection with Vote Now. One talks about the plethora of cases that are still out there battling against the false information that you guys are supposed to give to women, the 24-hour waiting period, the viewing the ultrasound, the lies about misoprostol and the reversal of crap. Let me just also say, I'm a lawyer and I work for Planned Parenthood, so this is where all this comes from. This session, I have another sheet out there that says all the things that the legislature that does not represent Kansas, 100% agree with that, have tried to do to limit the right to abortion and reproductive care. So those 3 sheets are out there. Take them. If you want to contact me, speak to me after. Thank you.
Sorry for the interruption, and we'll try and save a few minutes at the end for some questions from the audience.
I am gonna go ahead and move us into
Okay.
the audience questions.
If you have a question, just raise your hand and I'll make my way around. And while I'm doing that, let's give these ladies a hand.
This has been a wonderful presentation. Dr. Smith, when you talked about education, I just read an article the other day that the microaggressions, the rudeness in clinics and hospitals is part of why women of color are having worse outcomes. Why aren't they educated to be decent human beings? What the article said was the women that they've talked to that this happened to say things like, they say, oh, you're mad, calm down. When, if I said, hey, I don't think you're doing the right thing, they would listen to me. It's ridiculous. So why aren't they being educated to treat people?
I think that's a great question, and I think there are multiple answers to it. It's a long question because I think hospitals have been working for years to put in implicit bias training for providers, especially during the George Floyd era. But now they're having to roll back all of those things due to federal requirements that come from the person that sits at the White House. And so there's, here's the thing, I do weathering. Weathering is when a woman deals with a lot of stress throughout a day and it chips a little bit in her body. And for black women weather at 4 to 5 times that of anyone in any population, any race. And so what's happening is they're dealing with these microaggressions and it's chipping at their bodies a little bit. It's causing them to have chronic conditions. So when they go in to see their doctors, they're already chronic, right? Because they're taking in a little stress every day. And then they go into the doctor's office and they're mistreated. And they're chronic, right? And so it's very stressful, but I think also the angry black woman trope is a pandemic. It really is. It's a pandemic because a lot of times I can't be passionate about something. right? I can't come in and be passionate because I'm then labeled as the angry black woman, right? But I will tell you, I just finished writing a paper with Dr. Tracy Johnson and a colleague of mine, Pat Kelly, and it's on black tears, because, you know, white tears are liquid tears, because white women are allowed to cry. They're allowed to show emotion, black women are not. So black tears are anger, frustration, fear, right? Because by the time they show up to you and they've went through so many things, they're in a different headspace. There is no liquid tears. Nobody lets black women cry. Not when you're a baby, not when you're a young kid. Nobody, everybody tells you gotta be strong, because there's a strong black woman trope, right? It's embedded in our communities. It's even embedded in our religion. You heard about 1 Corinthians, God won't put more on you than you can bear. That's a lie. That verse does not say that. It says he won't tempt you more than you can bear. He won't allow you to experience more temptation. And so it's embedded that we have to show up strong regardless of what's happening in our lives. And that alone is killing black women, right? The reality is that we can't get care, because when we show up, we can't get the care we need. And even me, I have a 6'2" son, right? Had a car accident, we were in the ER, and they were wanting to drug test my son, who had a concussion. And I'm like, he has a concussion. He's like, why he can't stay woke? He has a concussion, right? But we literally could not get care until they drug tested him. So you have to realize that there's so many things that are happening, and when you get into the doctor's office, sometimes I don't even know if it's implicit bias or if it's racism. I just think people don't have enough experience with other races, right?
Yeah.
So they don't really understand, and because their perception of black people is built based on the news, right? And when you watch the news, let's be honest, if they show the person, oftentimes we're watching the news and they show a picture of the person, you know, that has done it, we know that's the black person did it, right? If they look at their background, it's a black person who did it, because they always want, Trayvon Martin was a kid, 75% teenagers smoke marijuana. Now marijuana is legalized, but when he got killed, murdered, the first thing they talked about was he was smoking marijuana. What does that have to do with him getting murdered? But that is the way the news portrays black people. And so many people have built their perception of black people based on what they hear. And that is a problem, and we're not dealing with that. We're saying it's implicit bias, but the reality is you need to get out and get to know some people. Be exposed to people. Put people in the same spaces, right? We need representation. You need everybody. A clinic should look just like the community. Everybody that's represented in that community should be represented in that clinic, and that is an issue, right? So I think, you know, there are multiple responses to that, but definitely, you know, doctors, nurses, social workers, we just talked about healthcare. But when you walk into a social service office to get help, they do it too. They mistreat people of color. And so we gotta talk about it on all levels. And we know our legislators do. They're not here today, but except for the great ones. But you know, that's the thing, is like on every level, people of color and black people are mistreated, right? And not thought of as humans. And that is an issue, because we all bleed red, right? And so I think that has to change.
Say I had a couple things. One was, I remember doing debate. As you can tell, I might be mildly outspoken, and I was so mad in high school debate because I'd be smarter than the people I was going up against. I mean, I'm just saying, men here just happened to be boys at the time, right? But we would be told by our coach, who was a fantastic coach, you gotta tone it down, because the judges, they're gonna immediately tune you out because you're a bitch. Like, that's what you're gonna be, right? You're gonna be overbearing and you're bitchy, and you cannot be that sure. You cannot be that impassioned. You cannot be that, And I was talking about that once with a group of women. We were all talking about it, and one of our black friends said, yeah, imagine what it was like for me. Like, and I hadn't even thought about that. Like, yeah, she did forensics as a black woman. And like, oh, that much worse, right? And just those things that I'm like, some of it is the reminding ourselves of like, oh yeah, but not only that we have experiences that are similar, right? That connect us with each other and find those things, but then also find that empathy and that understanding to see outside of ourselves to realize, holy crap, like it was even, different or worse for somebody else. Or I remember, mothering and speaking with other residents and other docs at a conference I was at. We were talking about raising kids, and we were talking about having kids, of a certain age that I've got twins that are gonna be driving at the same time. And we got into talks about, teaching your kiddos to drive and all of this. And one of my friends who's a doc in Wichita talking about teaching her son how to drive while black.
Yeah.
And just going, God, like these things I take for granted, right? Like, yes, I teach that when I teach my kids to drive, yes, you're respectful for a cop when they pull you over. Yes, you pull over and you do all the things, but I don't have to feel fearful that my child is pulled over by a cop, or teach my child how to make sure you're not gonna get shot at a traffic stop. Like, that is different. And so some of the things where when you come into a healthcare thing, right, it starts at the top. It starts from administration, it starts from the physicians, it starts from everybody not tolerating that behavior. And it starts with people being strong enough to stand up and say to somebody, not okay.
True
Right?
allyship.
Not okay, because that is allyship. It's not just saying it. It is, because it is freaking uncomfortable to call somebody out, to call a coworker out, to call anyone out. It's uncomfortable for me, and it's uncomfortable for all of us to say, what you did there was inappropriate. That was not okay. Take them aside later, but that's still hard to say how you misgendered that person, how you treated that person of color, how you did, like, that's not okay. We've got to make that culture. And what you said is so important about healthcare needs to look like the person who's getting the healthcare, right? Like, there's an awesome program that one of my colleagues in the AAFP is a huge part of. It's called Black Men in White Coats, and it's all about this, like, we need more black men in medicine. We need to have people look like them. We need to, I am vice president and on the board of directors for GLAMA, which used to be Gay Lesbian Medical Association, but it's health professionals advocating for LGBTQ equality, and we run the biggest, the largest healthcare directory in the world. And providers go in there, whether they're a dentist, a doctor, an eye doctor, a physical therapist, occupational therapist, whatever, and you can sign yourself up so that a patient can say, I am in Wichita, Kansas, and I need a dentist. Where can I go that I'm going to be safe? Where can I go that I'm going to be seen? Where can I go that I'm not mistreated? And things like that are also so important, because it's also, policing is the wrong word, but it's holding each other accountable.
Yeah.
As physicians and as places, and be like, why are you not on there? Or why has your, hospital not reached this standard or done this training? Like, it is keeping each other accountable.
Yeah.
So my younger kid, my older kid is non-binary, so that's a whole nother story. But my younger kid is an emergency medicine resident, but she went to KU Medical Center for her med school, and I kudos, because she definitely received that sensitivity training, and she still talks about it. She's in Newark, and let me tell you, it is a pretty diverse group of people walking in her door. So I just wanted to thank you for being among the faculty that helped teach my kid how to be a great doctor. So thank you for that. Probably the best course I ever took. I don't know if any of you are familiar with Uzazi Village, but the director of Uzazi Village came up, this was during the pandemic, so we're all meeting over Zoom, right? And she paired up people of different races together, a medical with a not medical, white person with a not white person, and we teamed up and we taught each other through learning different books. It was like a book club.
Yeah.
And we had assigned chapters and things like that. And then we just stayed talking with each other. We just continued that relationship. And that was an opportunity I would never have had if I hadn't taken that course. So if you have a chance to take something like that, it was amazing and it changed my life.
Yeah, it's now called Color Vision, but she did an anti-racism training and paired, because oftentimes, I'm gonna say this, because a lot of people are like, oh, you can't say that, but as a black person in the United States, I was born in the United States. and I've been here all of my life. And honestly, part of the things that I wanna do is I wanna go to Africa to deal with the racism inside of me. Because all I know is the United States, right? And I'm sure there are some, issues within me that are actually not right? Like, we all have things, and part of that pairing you with someone else that doesn't look like you is that the learning is reciprocal. I can learn from you, you can learn from me, but it helps me to deal with the things the perceptions that I have that may not be right. It helps you to deal with the perceptions, but we are just so afraid of getting in the same room because we often look different, we operate different, right? And you're talking about a girl who grew up in rural Arkansas on a farm, so there are plenty of different looking people, within my home. But the realities of things is that we have to learn how to have the hard conversations in safe spaces so that we can all be better.
And I have spent time in Zambia 3 different times in my life. First time for 3 months, and one of the best experiences of my life was going somewhere where I was the only white person, because there is no possible way I can understand what it is like until you have been in that situation. And their word for white person, and it's not pejorative or anything, but it's Mzungu. And so yeah, walking around and having just like walking through a village or through wherever, and just people pointing at you and Mzungu, and taking pictures of you, and you're like, yeah, this is good for me, because I grew up a white girl in Missouri, and like that was not the world I was in. So it was, yeah. And I always say, and Avery and I have talked about it, that like Avery has lived in Haiti for years and done work there. So we talk about how it's so important, like one of the best experiences our kids could have, any kid, any adult, whatever, is to go someplace where you were the minority when you have never been that minority.
Well, thank you for your question that opened up this discussion, and I think we have some actionable things to do, whether we're in a book club or with our friends and community. We are closing down our time. I'm so sorry we don't have more time for this discussion. And Dr. Ashley Bloom, do you or the panelists have any other actionable things for us to do as we sort of dismiss? Please don't forget to say hello to the people who are tabling here and pick up things along the way for your activist actions.
I had a few, we could talk about this for a whole nother day, a weekend, but I really want to challenge each of us in this room to think about what we can do to change the phrase political determinants and make it political drivers. These are things that we can change. We can take small actionable steps, whether it's going to the Capitol to Topeka. There's a Medicaid Expansion Advocacy Day on March 12th. I'm not able to make it, but you know what I can do? I can invite a group of friends over when it's an election season to host a postcard writing party. There are such small things that we can do that will help move the needle, and it's going to take each and every one of us doing that, but there is no action that is too small.
And I think the other thing is, if I can say, is that you live in a community, right? Each one of us lives in a neighborhood. How many of your neighbors have you talked to about Medicaid expansion and what it means? Knock on doors. I started knocking on my own neighbors' doors, and none of my neighbors look like me. But the reality is, if I could talk to them about truly what Medicaid expansion is, right, and what they're doing in the state of Kansas, they had no idea. I've only knocked on like 3 doors, but they had no idea. I do take cake with me. But I think the reality is, like, my thing is, like, I can't change the whole legislature. But one thing that I can is change the people around me, or at least educate them and leave them with something of like what they can do. There's so many flyers that organizations have developed about calling your legislators, writing your legislators, right? Opening your door to say, hey, I'm here if you have a question, right? And I walk in my neighborhood when it's warm. And so they can ask me questions, but I'm like, I don't know them, they don't know me. I'm tired of living that way. I want to be able to at least educate the people around me, right? And I also am able to talk to them about like calling the police. Because I do have a 6'2" son and his brother who's like often in and out of my house, and I do not need the police to come. I am a gun carrying rural Arkansan. I am okay. But I do talk about those things because they don't know, right? They don't know. If they see something, they're probably just like, maybe they may have a bias and they may be racist, but they may also be like, I've never seen this person, right? And so have the conversations with the people around you at the dinner table, your friends at work. Tell them how to be allies. How do you truly be an ally? How do you represent? If you're in a store, you see any woman being mistreated, any child, step up. Do something. I think that's the best thing that was said today. Like, do something, no matter how strong it is. Yeah. When they go high, when they go low, we go high, right? When they go real low, we go medium.
And can I add one more thing, Ashley? I just, that no act is too small, and just being kind and helpful to mothers and women, and really trying to catch your judgment or feel your judgment. I mean, even, I noticed that women judge on child names and baby names, and just don't do that. Yeah, and really, and everybody wants to hold a baby, but like nobody wants to clean a toilet. Like, just be helpful, you know?
I have two final things, and one of them is this whole idea of just do something, because it really all is interwoven, it really all is interconnected. So whatever is your passion, you're gonna see that string in front of you, that thread. Pull the thread, because if each of us pulls the thread that's right in front of us, the whole thing comes unraveled. So pull your thread and never, ever give up.
Amen.
And thank you all so much. I wish we had more time. We are going to hear from Suzanne Weichel, our representative here.
Woo!
She's going to speak to us for just a minute. Thank you so much.
Thanks, Kelly, and thanks for our fantastic panelists today. I'm Suzanne Weichel. I am Kansas State Representative for District 10 here in Lawrence. This is my first year in the state legislature, but I have been a Medicaid advocate both in Kansas and for a national organization for over 15 years. So I'm very, very knowledgeable about the Medicaid expansion. It was great to hear all the discussion today. I just want to make everyone aware, so this legislative session, I have twice put Medicaid expansion on the House floor as an amendment to existing bills, obviously knowing it was going to fail, but what that has given us is it's given us a vote on record of every single person in the Kansas House of Representatives. And so in Lawrence, all of your representatives voted for Medicaid expansion, but there are several from other areas of the state who have said, I know publicly, that they support expansion, but then they did not vote for it when it was on the House floor. And so I think a lot of us have ties in other parts of the state outside of Lawrence, and so if you're from a different community or you have family in a different community, I think it's really worth learning who their legislators are and how they voted, and start to have those conversations in other parts of the state as well. Thank you.
Thank you so much, Dr. Bloom. Thank you, everyone, for being here, and please visit our people who are tabling and get information, and we'll see you next month with Kansas Reflector, and watch for the Women for Kansas virtual town hall, April 7th, 7 to 9. Thank you all.